Hello, and thank you very much for joining the New England Baptist Hospital webinar series. We're very happy to have you here today. As most of you know, we are a specialty hospital and the only one in New England that works exclusively in orthopedic care. We see the largest volume of orthopedic cases in the area, and we have achieved a unique level of expertise, not only seen at the surgeon level, but also from all the medical staff that is involved in caring for our patients. This knowledge and expertise is what we would like to share with you through our webinar talk today, because we believe that education and knowledge will empower you as a patient to make the best decision relative to your health. We hope you find this webinar helpful, and we thank you very much for watching.
Hello, my name is Dr. Dana Zalkind. I'm the Medical Director of the New England Baptist Hospital Interdisciplinary Pain Management Program. Today, I'm going to be speaking to you about pain management, and this program talks about understanding pain and how you can, as a patient, can take back control. So, first of all, I have no disclosures for this talk, and our objectives today are going to be talking about, first of all, what is pain? And we're going to have a stronger focus this morning on lower back pain. Understanding pain is far from a perfect science. I have several objectives to discuss in this talk. I'll discuss again the definition of pain, both acute and chronic. I'll talk next about the incidence of pain and how it is a growing problem, both physically and financially. And next, I'll talk about how do we measure the subjective experience of pain. Lastly, I'll try to give you an overview of the multitude of treatment options. The treatment of pain can be a very challenging endeavor. So, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. This is the textbook definition of pain by the International Association for the Study of Pain. Pain is always subjective. Two individuals may experience the same nerve injury very differently, and these experiences are usually learned and programmed in our brains very early in life. Pain is always unpleasant and therefore becomes an emotional experience. And in order to treat pain, one needs to decrease the sensory input from the damaged tissues, change the signals which then travel to the central nervous system or your brain, and then alter the patient's emotional response to that actual or perceived pain. Doesn't sound so simple, does it? Pain is universal. It affects everyone, and it remains a public health challenge. Pain is generally considered chronic when it persists for longer than the expected time for the injury to heal. Other definitions of pain are pain lasting longer than 3 to 6 months. And there are many statistics, both from the US and worldwide, and the numbers are really striking. Pain affects 20% of adults worldwide. Chronic pain in the US affects more than 100 million adults. And chronic pain is really the real leading reason that people seek medical care. These numbers might even be an underestimation of the incidence of pain. There are still many individuals that do not seek medical care for pain. Reasons can be various. They can include there's no doctor available, they don't like the doctor available. In addition, there can be legal, financial, or geographical reasons not to receive care. So, how does pain compare to other common medical conditions? If we look at some of these statistics from a couple years ago, diabetes affects 25.8 million individuals. And if you notice the annual cost, $188 billion. Heart disease, stroke, 23.3 million individuals with a $309 billion cost. And cancer affecting 11.9 million individuals, annual cost being $243 billion. So, pain affects 100 million individuals each year. That's more than the combined numbers for diabetes, heart disease, and cancer. So if you suffer with pain, you're certainly not alone. Also, notice the annual estimated cost associated with each of these medical conditions is also fairly overwhelming. These numbers highlight an estimate of the implications of pain on the workforce. pain can lead to altered function and the inability to work, and then disability. So annually, there's over 50 million chronic disabilities due to pain, 515 million lost days of work, and $50 billion of cost to the employer. So when we put this together, pain can cost the nation up to $635 billion each year in medical treatment and lost productivity, and this is based on 2010 dollars. And so if you note that this $235 billion is comparable to almost the combined cost of diabetes, heart disease, and cancer. So after looking at all these numbers, I think we can all agree that pain is very expensive. This slide further delineates the huge burden of chronic pain, more specifically low back pain. So if we look at low back pain, it can account for almost 27% of pain complaints and anywhere from $50 to $100 billion of direct and indirect costs. And the interesting thing is the majority of costs are attributed to a minority of patients who become disabled due to inadequate relief of their pain. And although costs are very high, spine treatment is only a small percentage of an estimated $3.8 trillion healthcare industry in 2014. There are old estimates that this doesn't even include. In 2007, it was reported that Americans spent $7 billion from their own pockets on alternative medicine for low back pain. Examples would be acupuncture, over-the-counter medications, or chiropractic care. So when costs start skyrocketing in government-directed programs, the government usually likes to get more involved. In 2010, prompted by the Patient Protection and Affordable Care Act, the Department of Health and Human Services asked the Institute of Medicine to assess the state of the science of pain medicine and then make recommendations to try to advance the field. And they came up with a summary, and their report is called Relieving Pain in America, a Blueprint for Transforming Prevention, Care, Education, and Research. And this is what they determined. They determined that addressing the nation's enormous burden of pain will require a cultural transformation in the way pain is understood, assessed, and treated. So, what are the consequences of failing to assess pain? It's really important to assess pain. Otherwise, you'll fail to recognize and appropriately treat all the factors influencing pain and influenced by the pain, to the point that failing to assess pain results in failed treatment of pain. One needs to investigate a patient's level of activity, lack of activity, changes in interpersonal relationships, financial implications, and coexisting medical conditions, because all of these conditions can affect the outcome of a pain treatment program. So there certainly is a multidimensional nature to pain, and only the patient can explain what is of value to them and how pain prevents them from doing their desired activities. A pain care plan needs to take many of these factors into account, again, in order to be successful. And oftentimes, you will not know the important issues to a patient if you don't ask them. The best plan often needs to involve an approach dealing with several or all of these factors: physical, biological, psychological, financial, social, and cultural. To simplify the model of pain, it can be either acute or it can be chronic. Acute pain, by definition, is short-lived or less than 3 months. We call it adaptive, or a warning signal to protect the body from further injury. Acute pain usually resolves when the body heals. It can be nociceptive, which is a pain that triggers a withdrawal reflex. For example, if you burn your hand on the stove, if you pulled your hand off the stove quickly, you might not have an injury. You were warned. However, it can also be inflammatory, thus tissue damage can occur despite the warning. So touching the stove still can inflict a significant burn. Chronic pain is maladaptive. It is without really significant benefit. It can imply a malfunction somewhere in the nervous system. It can be neuropathic, which we describe as an abnormal function of the central or peripheral nervous system, or functional. There is no injury to the nervous system, but instead a faulty signal or an abnormal response of the nervous system. The fundamental expectation of acute pain is that it's going to disappear. It sometimes can be treated with analgesics or pain management medications. As soon as the acute episode resolves and heals, in theory, medications could be stopped. It, however, can still cause psychological stress or anxiety. It can cause physical symptoms such as increased heart rate, respiratory rate, and sympathetic nervous system activity. Somatic pain is pain that arises from injury to skin, bone, joint, or muscle, and visceral pain is typically due to injury to nerves or internal organs. On the other hand, chronic pain, the dysfunction of the nerves persists beyond the expected time to heal, and there's not really a physiological purpose for the pain. Oftentimes there's nothing to see, there are no visible changes. And this can oftentimes be difficult for a patient when you have a disease that really is not visible. There's no cast, there's no skin changes. To others, it may not even look real. It can oftentimes be difficult to have sympathy or understanding of something which you really can't see. And this can also lead to the psychological impact of chronic pain, which typically is exhibited as anxiety or depression. So, which way do you go to have pain relief? It's often confusing to decide who to see to treat your pain. Do you see your primary care, neurology, pain management, orthopedics? Do you go to your masseuse? Do you go to your next door neighbor's cousin, your therapist? Well, everyone has an opinion of what you should do or who you should see. And the beauty of it is no two opinions are ever going to be the same. The answer is that you might actually need all of these people. In many situations, patients go from one practitioner to the next in a sequential order in order to achieve the goal of pain relief. I often see patients after they've seen 4 different practitioners and they're still not any better. There's growing evidence that an interdisciplinary approach is a better way to manage pain with concurrent and collaborative care. You can use all of these individuals simultaneously, one-stop shopping. It's a goal we try to achieve here at New England Baptist Hospital. What happens when you're seen at the Pain Management Center? First of all, you need an initial pain assessment. There are lots of questions. We like lots of details. And next I'll be discussing each of these categories: history of pain, your medical history, addiction history, psychological, physical, diagnostic tests, and measurement tools. We're going to start by taking the history of pain. Most patients coming to see me do not have the story of skydiving for the start of their low back pain. In fact, in the past 20 years, only 2 patients came in to see me with that particular story. Most patients describe a more benign activity, such as bending over to pick up the paper, sneezing, or coughing. A pain history should describe the type and nature of the pain, when did it start, what activities are now limited, what's going to make it better, what makes it worse. And also we want to know what treatments have been a success and which ones have been a failure. I personally do not like to repeat a previously failed plan. Next, we're going to take your medical history, and yes, we want to know everything. If a patient has had severe heart disease, it might alter procedures or medications that are recommended. Steroids might not be such a good idea for a poorly controlled diabetic, as they can have side effects of elevated blood glucose levels. Kidney disease might preclude the use of anti-inflammatories such as Motrin. Multiple sclerosis might confuse a picture of spinal stenosis, since both are associated with pain and neurologic dysfunction. Post-stroke patients can present a confusing picture of pain and altered function. Migraine headaches can also present with neurologic changes. And if you miss the rash associated with the shingles, it might be a confused picture for a pinched nerve. So a complete medical history is certainly very important. A detailed history also needs to include information on addiction or potential risk factors for addiction. There's a multitude of screening tools available, And the 4 C's are a quick screening tool for addiction. So questions such as the loss of control over the use of the drug, continued use of drugs despite adverse consequences, compulsive drug use, or craving when the drug is then withheld. If any of these questions are answered yes, it doesn't mean that your pain needs to be untreated. Rather, it might mean that special considerations have to be done when prescribing medication. And although many screening tools are available, none are really 100% effective. Oftentimes, friends and family can be very insightful. Certain behaviors can be suggestive of drug abuse. Obtaining drugs from non-medical sources, stealing drugs, borrowing drugs, alcohol abuse, frequent emergency room visits, doctor shopping when you're going from one doctor to the next, to the next, to the next to get prescriptions, someone that becomes less functional at work, dealing drugs, or forging scripts. None of those are particularly good signs. Next, we want a psychological history. Pain can cause psychological change, and acute pain can certainly cause anxiety or irritability. Chronic pain is often associated with higher rates of depression. It can also be associated with a general lack of coping skills, hopelessness, or helplessness. And I really believe a physical exam is still very important to solve the mystery. Despite our world of technology, texting, emails, some things still need direct human contact. We need to assess a patient's gait, balance, muscle strength, a sensory exam, reflex exam. We also look for other pathology, tumors, bleeding disorders, infections, swelling, vascular disease, to name a few. Now, despite my best physical exam, I don't have X-ray vision. At least once per year, what I thought might be a disc herniation by physical exam really turns out to be a spinal cord tumor. Each test has a value, each test has a risk, and each test has benefit. For example, diagnostic evaluation you might receive, X-rays, plain X-rays, have a value for fractures, spinal alignment. They're very fast, non-invasive, and painless. CAT scan, also quick and painless. It can add a 2 or 3-dimensional view with reconstructed images. There is a risk of higher dose radiation, and it is okay if you have a pacemaker or an implantable device. It's still a scan that you could receive. MRI scans are very popular these days. They do not use radiation. Instead, a picture is created using a magnetic field. We use this to evaluate soft tissue, disc pathology. Unfortunately, it's not a scan you can go in if you have a pacemaker or an implantable device. Other things that we do, EMG studies, nerve conduction studies, bone scans, urine toxicology, blood tests looking for markers of infection or markers of inflammation are also helpful. So how do we measure pain intensity? Pain is a very subjective experience. And in this nice Photoshop picture, although these two animals are doing the exact same activity, one might have an easier landing and no pain than the other. And again, there's no lab test to give us a pain score. So why do we even bother measuring pain? It gives us a baseline by which we can judge effectiveness of treatment. We sometimes need to measure the level of impairment for disability or for compensation. This is an example of a unidimensional pain scale. Since pain is subjective, the patient's self-report is really the gold standard. There are many pain scales to assist with this task. The challenge can be, how do you measure pain in someone with limited cognitive ability, limited verbal skills, or how about children? This is an example of the Wieland and Wong Faces Scale, and it's really great for kids. Kids can point to the face that best describes their level of pain. The verbal numeric score goes from 0 to 10. 0 is no pain, and 10 is the worst pain ever. So whether you're using faces, word descriptors, or numbers, these are all unidimensional and measure pain intensity only. Another option is a multidimensional pain scale. One such scale is the Brief Inventory of Pain. The BPI has 17 questions. It's easy to administer. These questions assess pain intensity and also look at how pain interferes with general activity, work, relationships, mood, sleep, and overall enjoyment of life. The McGill Pain Questionnaire is also very popular. It can look at outcome goals for the patient, including self-care, family, social, or functional ability goals. Despite the best plans, patients may still have unrelieved pain. A goal of no pain may actually be unrealistic and actually unattainable. Sometimes we need to start with smaller goals, such as no pain while driving, no pain while getting dressed, and trying to actually enhance overall function and well-being and really make the patient manageable with their pain rather than eliminating it. Pain management is actually a dynamic and not a static process. Your first assessment should not be your last assessment. Ongoing assessments look at these factors continuously. I have patients that come to my office with great success, lasting 3 years, and now they're back again with the same exact pain. We repeat the same treatment with disappointing results. Well, why? Your spinal anatomy can change over time. You can have new disc herniations. Your arthritis can progress, osteoporosis. All of these can affect your outcome, and your plan might need to change based on these outcomes. So again, this also demonstrates reasons why pain treatments can fail. Although pain is a biological sensation, it affects thinking and emotion. The injury heals, but the depression gets worse. The disc herniation gets bigger. Job is lost, reduced income. Pain medications give too many side effects. Your family and friends are not really understanding this whole scenario, and now they're mad at you. You've had a second new injury. All of these can affect pain relief. So we're going to talk briefly about low back pain and conditions associated with low back pain. This is a huge topic, and this is a potential list of causes of low back pain, and this is probably an incomplete list, I might add. Most episodes of low back pain are actually not a surgical issue. There's not really a quick fix. The goals are usually to use mild analgesics, reduce inflammation, restore proper function and strength, and really prevent reoccurrence of the injury or try to prevent a new injury. There are many treatment options for pain, for whether it's low back pain or pain in general, and typically I think it's better to start with a less invasive option and move to more invasive options if the less invasive options have failed. Each treatment option listed here has its own associated risk and benefit. So to start with, ice or heat, cool or hot. There's actually not great evidence for either. For a new injury, a cold compress for 20 minutes on and 20 minutes off. That bag of frozen peas are perfect. You can decrease pain and decrease inflammation. After several days, however, or with chronic pain issues, I usually would switch to heat to increase blood flow to the area and help with muscle relaxation. Believe it or not, they have risk. There is risk of frostbite, there is risk of burns, so either modality needs to be used carefully. So, to rest or not to rest, gone are the days of bed rest vacations. Nowadays, if you had open heart surgery, you're probably not even resting for a week. It can be risky to do nothing. Secondary complications of rest include increased risk of blood clots and muscle weakness. Starting to move sooner seems to have better outcomes. It's better to improve strength and better to improve overall flexibility. Exercise is important. You might not want to try this at home right away, but back healthy exercises include stretching, yoga, Pilates, swimming. They help to develop proper posture and muscle balance. Walking is a great exercise. If pain is progressive, you should heed to those signals and adjust your activity or training. A good goal is core strengthening, and if things do progress, you probably should refer to your physician. Medications are also another option to treat pain. There are many medications that claim to treat pain. Just walk through your local pharmacy. Some are prescription medications, and many more are over-the-counter or from a holistic source. Medications are not all in pill form. Some are sprays, creams, patches, suppositories, injections, and there is a risk and benefit to each of these. They can be expensive, they can have medical risk, and you should always have the approval of your physician. This is a listing of many different classes of drugs which are used to treat pain. Some are more commonly known and some are less commonly known, but we do use multiple types of medication to treat pain. We use non-steroidal anti-inflammatories, we use muscle relaxants, antidepressant medications can also be used to treat pain. Opioids are probably more well known to treat pain. They have their associated risk and benefit, and even anti-seizure medications or membrane stabilizing medications such as gabapentin, Lyrica, all can be also used to treat pain. Physical therapy is an integral part of recovery by improving muscle strength and mobility. Many different types of therapy can be done, including traction, TENS, ultrasound, reconditioning, and it can be done by land or by sea. Acupuncture is a treatment which has certainly withstood the test of time, has been documented for well over 2,000 years. Acupuncture is an old technique. It involves the insertion of teeny needles along precise points of the body. This triggers the release of naturally occurring pain-killing modules called peptides and keeps the body's normal flow of energy unlocked. Acupuncture might take multiple sessions, and unfortunately, cost and limited insurance coverage seems to be one of the bigger limiting factors of acupuncture. Other alternative care can involve chiropractic care, biofeedback, stress management and relaxation training, and massage therapy. There are many other alternative therapies as well that have been successful for pain care. Interventional pain techniques are a huge field unto themselves. My practice specializes in interventional pain techniques. There are many different types of procedures ranging from a simple trigger point injection into a muscle or an implantable device such as spinal cord stimulation. It's an enormous topic which we will only be highlighting in this talk. Why do interventional treatment? There are several reasons. One is it can help diagnose where the pain is coming from. Two, it can be prognostic and allow the patient to experience a temporary blockage of that nerve and for them to answer whether or not that is truly a better experience. And lastly, hopefully it can be therapeutic and actually improve the pain. Advantages are these procedures can be done with a very low risk if done by an experienced provider in a safe environment. It might allow patients to be on lower doses of medication and might complement their other treatment programs. There are a few examples of some procedures done in our practice: spinal injections, lumbar epidural injections, cervical epidural injections, nerve root blocks, facet injections, joint injections, peripheral nerve blocks, spinal cord stimulation, radiofrequency ablation or rhizotomy, lumbar sympathetic blocks, Botox injections for migraine, plasma-rich platelet injections, and even viscosupplementation for joint dysfunction. This is an example of a lumbar epidural steroid injection. It's a common procedure done in pain practices, typically done under X-ray guidance, which is the radiograph that you see on the left, and there's a cartoon image of the same picture on the right side. Facet injections are very commonly done for low back pain. They can be very successful to help improve mobility of the spine and amenable to injection therapy. Again, there is the X-ray radiograph on the right and the cartoon model next to it. Radiofrequency ablation or radiofrequency lesioning is also an old procedure and not a new procedure. This is a neurodestruction procedure, which can again be done on an outpatient basis and most typically used for patients with facet syndrome that do not have long-term relief with steroid injections. This might give them a longer period of relief, 6 to 12 months, which then allows patients to be more mobile and overall more functional. So in summary, many factors contribute to pain relief. One needs to remember that there is more than one solution for every pain syndrome. The key is discovering the right solution for your individual pain issue. Here at the New England Baptist Hospital, we're equipped to help you navigate this journey, which oftentimes can be overwhelming to navigate on your own. Pain is a significant health problem. Pain is a multidimensional phenomenon, with no two patients being exactly alike despite appearance. Success is much more likely with an interdisciplinary team approach. Thank you very much for your time today.